Obviously, filtering blood is very important for the kidneys. Wide range of disease of other organs manifest in the kidneys, and we'll go through some of them today. Usually, a patient is going to be asymptomatic until enough of those nephrons are destroyed where you have an issue. Really, no pain with renal disease unless it has any like the ureteral or renal capsule. So polycystic kidney disease has a lot of growths going on with the kidney, so it presses on that renal capsule, causes a lot of pain. And ureter, if you ever had a kidney stone or know someone who had a kidney stone, a lot of pain going on, and it helps with that, pain with the kidney stone. Early stages of kidney disease, oliguria or composition is off. Late stage, they get the edema, fluid overload. So one of the key things, I know you guys are studying cardio now, is right now, I know every question that you're going to get on your exam is cardio based, but later on you have to figure out, is this fluid overload, is it because their kidneys are bad and they can't filter out the fluid, or is it the heart that's bad and things are getting congested? So is it a kidney problem or is it a heart problem? And obviously we know acid base is involved with regards to the kidney as well. Do a quick little review here. Kidneys don't weigh a whole lot, only about a quarter of a pound. Size only 10 to 12 centimeters, not very big, very, very small kidneys. Lies retroperitoneal space. Make sure you remember that one because of it's not within the abdominal cavity, it's outside of that. 11th and 12th ribs, that's why you do your CVA tenderness right there to see if they have any tenderness in that renal capsule. Are you eliciting any pain? And that's why you hit them there. Right kidney is a little bit lower. We have the renal cortex and the medulla. Cortex is the outer layer, the medulla is the inner layer of the kidneys. We also have the hilum that faces the vertebral column. We have nerves that go in through here. That thin fibrous capsule or the renal capsule that covers the entire kidney. Kidneys drain urine via gravity. It goes into the bladder. Peristalsis will move urine through the ureters into the bladder. And we went through all those bladder stretch receptors, how the bladder starts to get full, and it will start to send signals to the brain, the micturition center in the brain, saying, hey, we're starting to get a full bladder. You might want to have to go to the bathroom pretty soon. And there's our kidney. Obviously, we have the cortex layer on the outside. We have our medullary area on the inside, these medullary pyramids or renal pyramids because they look like pyramids. So you draw it out. 20% of our cardiac output goes to the kidneys. So a lot of cardiac output goes there, helps with our filtration. It would make sense. That's why the kidneys and the liver get a lot of the blood to clean it out for us. So we want to remove urea and any nitrogen-containing compounds. And obviously we know extracellular fluid is very important as well because it's going to help maintain our fluid volume status with regards to like osmolarity and all that stuff, with regards to what hormone is very involved with water balance. Aldosterone, and what's the other one? ADH. Blood flow goes from the cortex into the medulla. So when we have those juxtamedullary nephrons that go deep into the medullary cavity, they help prevent against ischemia. They hold blood there, but they're also susceptible to ischemia and they get damaged as well. The nephron is the functional unit. Each kidney contains close to 1 million nephrons. There's no exact number, but we don't actually get any form of renal impairment until 75 to 90% of those nephrons are damaged and destroyed. So there's not going to be very much. So when your kidneys are at 50% function, you're still not going to have any renal impairment. It takes by the time you start getting kidney damage, 75% of your nephrons are already destroyed by the time you start getting any clinical signs of it. Two types of nephrons, cortical and juxtamedullary. It depends on where they're located and how deep they go. Function, again, water-soluble substances gets it out of the blood. reabsorbs any filtered nutrients, water, or electrolytes that we dumped into the filtrate that we want to bring back into the body, secretes, and then obviously excretes out of the into the filtrate, into the urine. Endocrine functions, EPO and vitamin D. This should be reviewed. We've gone over this many times now. Kidneys, EPO, vitamin D are the big things they do. Here's a graphical of our nephron again. Remember what the definitions for filtration are: reabsorption and secretion. Secretion is going into the tubular fluid outside the Bowman's capsule. The filtration occurs inside the Bowman's capsule. Reabsorption brings it out of the tubules back into the blood. And then excretion means you just peed it out. Here's just another graphical representation talking about, this is a juxtamedullary nephron because it goes all the way deep into the medullary area. With regards to our anatomy, we have the glomerulus, which is like the property. It's the entire thing. It's the afferent, the efferent arterioles, and the Bowman's capsule come together to make the glomerulus. So it's your afferent and your efferent arterioles. They come in, they get all mixed up inside that Bowman's capsule, provides a lot of surface area for diffusion of the waste products, and then obviously the reabsorption of all the nutrients to bring them back in. A couple of things to note: when we have a barrier here, we have these podocytes. We talked about podocytes before. What other barrier are these podocytes? The blood-brain barrier. They are here as well to prevent any big cells to get through. What are the big cells that we don't want getting into the filtrate? Not glucose. Protein is one of them. Blood, the red blood cells. We don't want red blood cells. We don't want protein to get into the filtrate. We want to keep them out. These podocytes help maintain that barrier as well. So the size of the solute matters. We also have this basement membrane. The reason why I'm pointing these things out is because they're going to become prevalent when we talk about different types of glomerular diseases. We also have mesangial cells, and they kind of live in between the capillaries. We'll go through these properties in a little bit as far as what they do. But these are the parts of the glomerulus. And here's another way of looking at, again, the Bowman space. Here are the foot processes of the podocytes, again, providing more of a gate to prevent these proteins and red blood cells from spilling through. We don't want them in the urine. We're going to go through some diseases today, talking about if you have a lot of protein in the urine, what's it called? They're called nephrotic syndromes, with the O for protein. If you have nephritic syndrome with an I, that means you have blood in the urine. So that's why it's important when we get to those different diseases later on. Again, just going over the different areas of the nephron, loop of Henle. I'm sure you got very familiar with that with furosemide and Lasix with Dr. Wood. So there's our loop of Henle again. So the glomerulus, site of fluid filtration from the blood to the nephron, surrounded by the Bowman's capsule, has this basement membrane. That's a selectivity barrier. We don't want plasma proteins, red blood cells, white blood cells, platelets from going through. So they stay in the blood. GFR is about 125. What's the magic number I told you to remember? 60. So we get below 60, we start having some kidney problems. That means that enough of your nephrons have been damaged that now you're starting to reduce your kidney function. Mesangial cells, those are those cells that kind of line in the interstitium between all those capillaries. They help with immune function. That's their job. And helps with surface areas. Remember, anytime we talk about diffusion, surface area is a big deal. When you reduce the surface area, you have problems. We talked about it with the lungs. When you have a PE, you reduce the surface area for diffusion because parts of your lungs aren't being diffused or perfused, so therefore you have issues. Mesangial cells, again, these are part of the immune. They have characteristics of smooth muscle cells. So because of that, they will contract and relax in response to vasoactive substances. So therefore, they're going to influence the GFR as well. They generate prostaglandins, help with inflammation, synthesis of cytokines, and uptake of immune complexes. So again, a lot of immune function with these mesangial cells. When they get inflamed, think of it, they're compressing those arteries, the arterioles. So what happens to the diffusion? What happens to the radius of those vessels now? Decrease in the radius, therefore what happens to the flow? Decrease, therefore our like that gets reduced as well. So you can see how mesangial cells do have a small influence on GFR as well. Proximal convoluted tubule, this is where a lot of the stuff gets dumped in. Most of our reabsorption occurs here with water and electrolytes. I'm not going to ask you anything else in this as far as like just where they're located. If you wanted to review your stuff, I'm not going to ask you on this test. Loop of Henle, we understand that descending limb is only permeable to water. Ascending limb, obviously is going to have your sodium, potassium, and chloride. Remember, it's a triple receptor. Where does Lasix have its effect? What do they block? The chloride channel, and that shuts the whole thing down. Right? Juxtamedullary nephrons help with the concentrate of the urine, so they can like really control the water balance with those ones. Distal convoluted tubule, this is the one that's under your aldosterone effect. Atrial natriuretic peptide is here as well. Remember, at the distal convoluted tubule, this is for that fine tuning of your balance of these electrolytes. So it's going to be under more of a hormonal control to raise and lower that depending on what our body needs. The collecting duct, these start to have all the merging of all the other collecting ducts from surrounding nephrons. They finally pour into these minor calyces. We have two different types of cells. We have P for principal cells, and they respond to ADH. So they have those aquaporin channels. We also have I cells or intercalated cells. They help with acid-base balance. So because we're dealing with acid-base, you know it's got to be hydrogen and bicarb are the ones that are affected most by these intercalated cells. So principal cells, water, think ADH, aldosterone, atrial natriuretic peptide. The intercalated cells, the I cells, are for acid-base. So it's got to have something to do with hydrogen and bicarb. Age-related changes in kidney function. Normal age-related changes. Kidneys reduce in size and function by the 6th decade. They shrink by about 20% in their 8th decade. They get primarily a loss of glomeruli. 30 to 50% of their glomeruli are gone by the age of 70. So we know over time as we get older, renal flow decreases about 10% per decade. So if you know that you have a drug that is renally metabolized, if you're dealing with geriatric populations, because we know kidney function reduces over year, don't give them a normal dose of a medication because they're not going to be able to clear it. So it's going to build up in their system. So if you give them a high dose, it's going to stick around longer in the body, potentially build up, cause adverse events. So that's where you get into that polypharmacy deal and too many medications. What are they on? We have a whole geriatrics class for you guys to take in the winter with Professor Stewart that'll go over a lot of this stuff with what considerations for geriatric populations. Okay, so that's our intro. Let's get into types of renal disease. When we talk about renal disease, they're kind of like we classify them by two different ways. The first one is the site. Where is the problem? Is it a glomerulopathy? Meaning, is it a problem with the glomerulus? The arterioles going in and out, the Bowman's capsule, something is going on with the glomerulus itself. And there are two types of glomerulopathies. The first one is nephrotic disease or disorders with an O. And they have proteinuria without inflammation. So there's no inflammation with these patients. They're spilling proteins. The next one is nephritic disorders with an I. And they may have some proteinuria, but they are going to have red or white blood cells in the urine. So that's the disorders of the glomerulus. The other way is tubulointerstitial. Is it a problem with the rest of the nephron tube going all the way to you get to the common collecting duct? So we look at it by the site of the problem. Is it in the glomerulus that's the problem? Is our nice sieve that we use to clear out big particles, is that starting to be weakened now? So a lot of these proteins are starting to get in. Or is it a problem with this tubulointerstitial, the rest of the tube going out the rest of the way? So where is the problem? The other way we look at these things is the cause. What is the underlying cause? Is it immunologic? Do they have an autoimmune disease going on? Is it lupus? Remember we talked about how lupus, wherever those complexes get lodged in, they're going to have a problem. Well, if they get lodged in the kidneys, it's going to cause kidney failure. But it's due to an immunological problem. Metabolic issues, cancer, we'll do it. Infectious issues, hemodynamic. What would be an example of a hemodynamic problem causing ischemia? So what would cause the renal system to have ischemia? If you have congestive heart failure, is your output reduced? So the output is reduced. Kidneys don't like it, they don't sense it, and they get affected by the low volume. We call that pre-renal disease because it's something happening to the kidneys before you get to the kidneys. And toxic, did you do a bender of cocaine over the weekend? That'll blow out your kidneys real fast. So toxic problems can do it as well. So nephrotic disorders with an O. Really read the questions on your exam. Don't glance through that too fast and you confuse nephritic with nephrotic. They will look the same on the exam when you're reading it too fast. So nephrotic disorders, immune complex deposition at or under the epithelial cells, and they affect the foot processes. So remember we talked about the foot processes help with a barrier. So bigger solutes don't get through. Well, now we're changing the foot processes so bigger particles can get through. So these, remember we had that one graph in physio talking about how at these higher size, and this is the permeability, right about here when everything gets cut off is where albumin is. So albumin is just big enough that it doesn't get through, but it's very, very, very slight. It's not much. So when you start affecting these foot processes, bigger particles can get through. Proteins are right there, ready to go. And as soon as that gate opens up, protein can get through, they're going through. So that's what we're talking about here. Lack of cell immune response may limit the damage done. It also slows the resolution of the disease. So because of that, proteinuria takes months to years to resolve. They'll have protein, they may feel better, but it'll take a while before the protein levels in the urine go back to normal. Nephritic disorders with an I. Again, immune complexes, but in this case, it's subendothelial or glomerular basement membrane is affected, or those mesangial cells in between those arterioles. So nephritic disorders affect these layers. The nephrotic disorder is just the epithelial cells that surround the vessels. The inflammatory process can be a double-edged sword with nephritic disorders. So you do have some inflammation with nephritic disorders. In a controlled way, phagocytosis of subendothelial deposits speeds the recovery. But in an uncontrolled reaction, greater degree of destruction of the architecture of the glomerulus, so we have more disease spread, more destruction from the inflammation. So controlled, we have enough time for our process to take over. Uncontrolled, we don't. Certain kidneys are very susceptible to certain kinds of injury. So hemodynamic factors, anything dealing with blood flow, have very big effects on the kidney because it's going to reduce the GFR due to reduced renal blood flow. And because when you have this low blood flow to the kidney, they're very susceptible to ischemic injuries. So anything with hypovolemia going into the kidney is going to cause problems. The renal medulla is a low oxygen tension environment. Not a lot of oxygen down there. So again, whenever you reduce the oxygen delivery to these areas, they're going to have very susceptible to ischemic injury. The glomerulus is the initial filter of all the blood entering the kidney. So the site of injury related to the immune complex deposition and complement. So that's where everything comes in. So everything hits the kidneys right there first. That's why the glomerulus is the first one to get hit. So what happens when you get altered kidney function? Accumulation of urea and the inability to maintain electrolyte, water, and acid-base balance. That's why we look at the BUN as well to see the kidney damage. Because obviously we can't get rid of the urea, so it starts to build up in the blood, and your BUN starts to rise. Elevation of BUN, serum creatinine results in uremia. Absence of adequate renal clearance, ingestion of excess amounts of sodium, potassium, and water, or acid results in electrolyte volume and acid-base abnormalities. What does that mean? Kidney patients, people who have long-standing diabetes, they're on dialysis all the time, they have to be careful with potassium and salt. If they eat a big bag of chips, the body won't be able to handle that. They're going to fill up with fluid like crazy. If they eat a lot of stuff with a lot of potassium in it, the potassium levels can rise because they can't get rid of it. What happens with renal patients when potassium level starts to rise? All those cardiac issues start to pop up because the threshold gets reduced. So that's what we're talking about there. I just talked about what happens when you take too much salt. So if they have a very salty meal, all this extra volume can lead to hypertension. And if the patient already has underlying heart disease, they can go into heart failure as well. So fluid overload is very bad. Find out again, is this a renal problem or is it a cardiac issue? Okay, so let's start learning about acute renal failure or injury, pre-renal, intra, or post. Okay, so we talk about acute renal failure in 3 different ways. Pre-renal failure, this is an issue before the kidneys. Hypovolemia is one example. You have low blood volume, that's going to cause the kidneys to have an issue. There's nothing wrong with the kidney itself. It's something that happened before it got to the kidneys. Intrarenal, this is actual damage to the nephron itself. Anything dealing with toxicity to the kidneys. If I say a drug, is toxic to the kidneys, it's going to cause issues and so on and so forth. It'll cause intrarenal disease because you're damaging the tissue of the kidney itself. Or postrenal, anything in the collecting system, the ureters, the bladder, the urethra. The prostate in males is also here as well because that could also cause obstruction to cause issues later on. So this is all based on the location. So when you're reading a question about this, figure out what is the problem. Is it damage to the kidney itself? Is something before we even get to the kidney? Or is this a problem after the kidneys? Ureters, bladder, urethra, prostate in men. So here's the way to look at it. Pre-renal, anything prior to the renal arteries. The next one, intrarenal, kidneys themselves are the problem. The last one is post-renal, ureter, bladder, there's your prostate, urethra. So when you're looking at different ways of looking at kidney failure in the acute kidney failure, is this a pre-renal problem, intrarenal, or is it a post-renal problem? Your question information will give you those answers. So what causes pre-renal failure? Volume depletion, hypotension makes sense. Not a lot of blood going in there. Heart failure, because you have reduced cardiac output. Therefore, less perfusion going to the kidneys, reduction goes down. Hepatic cirrhosis, it just goes along with more of the congestion of the blood getting stuck in certain areas. NSAIDs are pre-renal. Okay? And your bilateral renal artery stenosis, meaning both sides, both renal arteries have atherosclerosis. We've already gone through in the cardiac section why you can get atherosclerosis in the renal arteries. What are the underlying causes? It's all the same here. We're not going to review it because we already did. So these are all pre-renal problems. Post-renal issues. Anything outside the kidneys going to outside the world. Obstructive uropathy, so something in the ureter, the bladder, urethra is making a blockage. Here's calculi or renal stones. Prostatic disease, so BPH. Malignancy, cancer, or any congenital abnormalities. But again, something is blocking the release of the urine. Do the kidneys know that there's a block? What are the kidneys going to keep doing? Producing more and more urine. It's going to keep pouring out. And if you have a blockage, what's going to happen to all that urine? It's going to back up. And it's going to back up into the kidneys. If it does that, that is hydrosis of the kidney, which is basically water on the kidney because it backed up so much, it's starting to fill back up into the kidneys, and it'll cause problems there. There's another word for that. I can't remember what it is. It starts with a P. Drawing a blank right now. So those are the post-renal issues. Now let's talk about the intrarenal problems within the kidney tissue itself. Malignant hypertension. Having high pressure go through these arterioles will damage those arterioles as well. So malignant hypertension destroys the glomerulus. That's why hypertension leads to kidney disease later on, because having that high pressure all the time busts those arterioles up. Scleroderma. Scleroderma, whenever you hear that, think of infiltrative disease, restrictive disease. If something is fibrosis is going into a tissue, it's not going to work as well. It can also happen in the lungs. They have to go on breathing help assistance later on. Thromboembolic disease. You just throw a clot. The clot got lodged in the kidney. That's all that is. Here's your glomerulonephritis. So again, disease of the glomerulus, the Bowman's capsule, the arterioles, nephrotic or nephritic syndrome. Here's your acute tubular necrosis, multiple myeloma, and pyelonephritis, which is, I think that's what that is. I'm remembering. That's the water on the kidneys. And it causes you to get sick and you get a fever. Okay, so those are different causes. And we're going to go through some of these. Okay. So pre-renal, GFR determined by two factors, the afferent and the efferent arteries. Remember all that stuff we did over the summer, that fun drawings? When you constrict the afferent, what happens? Constrict the efferent, all that stuff. So problem with either flow in or out, either we can't get it into the glomerulus or we can't get it out, is going to cause issues with filtration. Decreased flow in, diminished filtration. Less blood in, less filtration, more blood in, more filtration going on. So pathology can develop NSAIDs that block the prostaglandins. They get prostaglandin-mediated vasodilation. Patients with renal hyperperfusion, renal artery stenosis, dependent on angiotensin II to get all that stuff out. may get ARF, acute renal failure, if they have ACE inhibitors. Because ACE inhibitors inhibits angiotensin converting enzyme, which we know does what to the efferent arterioles? They dilate. So when you don't have it, they constrict. What happens? All that stuff, it goes problem. So that's where those things come into play. Here's your ACEs. Here's your NSAIDs on your afferent. The ACEs are on the efferent arteriole. So remember, when you give certain medications, so we talked about musculoskeletal. What's the most common drug to give them for osteoarthritis? An NSAID, right? To help with pain. But now, what if they have kidney disease? Are you still going to want to give that NSAID? No. That's going to be a type of question on your exam because guess what? We have renal and musculoskeletal on your exam. So they're both going to be there. So you got to get all of them. So they'll all be there, all those questions. Again, here's how NSAIDs block the prostaglandins. NSAIDs block arachidonic acid to prostaglandin directly. And that's how you reduce your prostaglandins. Pre-renal, 60% of all cases of acquired acute renal failure are going to be pre-renal. Most of them is going to be due to lack of perfusion is the biggest cause of pre-renal ARF. Decreased GFR leads to decreased volume of blood. Therefore, we have increased sodium and water resorption. The goal is to try and increase our GFR. But we get hypoperfusion, and that causes the renin system to start. And the way we do that, again, get the renin system going, aldosterone is going to cause increased sodium and water resorption, and it's going to dump out potassium. We get azotemia, increase in the nitrogen products, increased bond and creatinine. Oliguria, which is little urine production, easily reversed if the cause is found. So once you start noticing, you check your eyes and nose, what are they ingesting, how much liquid are they drinking, and how much urine are they producing. They should be very close to each other. If what you're drinking is less than what you're peeing, then all that fluid is staying in your body. That's what we look at. Intrarenal problem. Either the glomerulus, or it's the tubules. But big thing is the nephron is damaged. Either it's the glomerulus or it's the tubes. Most common renal tubules, so acute tubular necrosis is the most common cause of intrarenal failure. Injury is either ischemic or nephrotoxic. So did you give a drug that caused disease to the tissue of the kidney, or is it just because of ischemia causes acute tubular necrosis? More damage will occur with the ischemia. So necrosis, right? We're killing off these things because of lack of oxygen. We have low volume going in, causes all that stuff, the fun stuff to happen. Recovery can take weeks or months, and it can progress to chronic renal failure. And we'll talk about where's the cutoff. It's all about time. How long have you had low kidney function before you considered chronic renal failure? So here's another way of looking at it. You have your acute renal failure, pre-renal, intrarenal, or intrinsic, and your post-renal. And this just kind of breaks down when you're studying the different types of interstitial disease that can happen. Many causes of intrarenal pathology, tubular disease is the most common, the acute tubular necrosis. Drugs, ischemia, infections can cause this to happen. The glomerular diseases, either nephritic or nephrotic, and we'll deal with those later. So as far as intrarenal issues. Post-renal, anything dealing with blockages of the urine of flow, distal to the kidney itself, any level of the urinary tract. Intrinsic cause, nephrolithiasis. So you have a kidney stone that's blocking the passage of urine. That's an intrinsic cause. Extrinsic, retroperitoneal mass compressing a ureter. So I said, remember, the kidneys are retroperitoneal because you have to consider these things too. Any mass retroperitoneum can compress the ureters, causing obstruction of urine. Result in oliguria, anuria, produces an increase in retrograde pressure within the kidney, Bowman capsule, glomerulus, all reducing your urine production. Around 15% of cases, less than 50%, are a post-renal, and usually just remove the obstruction and they're fine. All forms of acute renal failure, if left untreated, will result in acute tubular necrosis. When this happens, those epithelial cells start to slough off and get stuck in the tubular fluid. So depending on timing between the intervention and onset of the injury, the acute kidney injury, acute renal failure can be reversible. But again, the timing and how fast correction did you do? There's two theories in the development of this acute tubular necrosis. One is a tubular theory, which states that the occlusion of the lumen with this cellular debris that's falling off, kind of like in acne, we talk about the keratinocytes sloughing off and plugging the pore. Same thing here. They slough off and they plug the tubes so nothing can happen. Offsets perfusion pressure and abolish net filtration pressure, causing more ischemia. So they form what's called casts. So whenever you hear about a cast from a urine cast, you have to know what is it made up of. Is it a red blood cell cast? Is it white blood cell? Is it platelets? Well, I'll show you pictures that will show different types of casts when we get to it. The other one is the vascular theory, that when you have decreased renal perfusion pressure from either afferent vasoconstriction or efferent vasodilation, reduces the glomerular filtration, therefore everything reduces. Maybe one or maybe both that contributes to acute kidney injury. We don't know for sure, but those are the two theories as far as what's going on with those cases. Clinical manifestations for acute renal failure: morbidity, an independent predictor of mortality. Initial symptoms: fatigue and malaise. Very, very nonspecific, can be anything. But later on, signs of loss of renal water, salt excretory capacity, so they can't get rid of the salt in the water, so it starts to build up and they get fluid overload. So dyspnea, orthopnea, rales, third heart sound, peripheral edema. Sounds like what? Right-sided heart failure and left-sided heart failure. Mainly left, but we have both, right? So heart failure, it looks like heart failure, but you have to know, is this kidney problems or cardiac? How do you know the difference? What do you check? GFR, check their kidney function. You get a BUN creatinine. If they're both really, really high, it's probably due to renal issues. And obviously you get your medical history, but that's what you would look at. If they present with altered mental status, that's the effect of uremia on the brain. So when we can't clear the urea, we get uremia, excess urea in the blood. This will cause confusion, altered mental status in those patients. Lab changes, obviously BUN creatinine go up. Serum changes, electrolytes go up because we can't clear them as well. Phosphate goes up. We can't clear that as well. You get hyperkalemia, which is the worst one. Potential decreased serum calcium. Why? Not making active vitamin D. That's one of the major things for vitamin D. And decreased erythropoietin production. So what may happen to them later on? They become anemic because they're not making the red blood cells anymore. So you need to go on medicine to help boost all that. In the urine, here's your granular and epithelial cell casts. Is it red blood cell, white blood cell, platelets could be those? Is it epithelial cells? You'll see pictures. Do they have white blood cells? Proteinuria may show up if it's nephrotic syndrome. Decreased urine osmolality. Kidneys aren't filtering any products from the blood, therefore low products in the urine. If nothing's going into the Bowman's capsule, nothing's going to wind up in the urine. So it's going to be low in the urine. So these are the different types of casts. Again, they get lodged in the tubes, so they look like the tube that they formed in. You can get red blood cell. Here's what white blood cell casts look like. These are your epithelial cell. You can get a broad cast and a hyaline cast as well. There are different types. Urinalysis will show all of this. So when you get a UA, it'll tell you what's going on if it sees any of that stuff. And yep, okay. Last two slides, take a break. So phases of acute renal failure. So it's a transitory phase. You can't stay in acute renal failure forever. Either you're going to get better and you're back to normal kidney function, or you get worse or remain that way, and now you go to chronic renal failure. So the oliguric phase, the low production of urine, lasts about 1 to 2 weeks. Urine output is less than 500 mLs in 24 hours. You can get anuria, which is really low, less than 50 mLs of urine production in a 24-hour period. If you have that little urine production, it's severe tubular damage is what happened. Then we get a diuretic phase. Then we get large quantities of dilute urine are produced, kind of like the kidneys woke up again and got better, and now they start going overdrive to kind of compensate for what was lost before. Large dilute urine, this is the diuretic phase. Tubular patency is restored, so therefore all that fluid can get out now as the kidneys are filtering, so all that water is going to, or the filtrate is going to dump into the urine, more production. This can last 2 days to 2 weeks. And then finally, we have a convalescent phase where we have full or partial recovery. That can last, 8 days to up to a year. All you got to do with these patients, just keep checking their BUN creatinine, get a BMP every 6 months and see how they're doing. So either it resolves or you turn into chronic renal failure if they're not resolved. So let's take a break. Come back at 3:25. Okay, let's get moving here. Keep going. So we talked about acute renal failure, acute kidney injury. We said that the different causes, any of the causes that result in acute can cause the chronic ones. There's a bunch of other ones, but obviously we talked about how with acute renal failure, it's that transition period. Are they going to get better or are they going to get worse? So chronic renal failure, loss of function over months to years. So the definition of chronic renal failure, kidney damage itself, or GFR is less than 60 for 3 consecutive months or more. That means it's not returning, kidney failure is not getting better, BUN and creatinine are staying elevated, they're not coming back down. That means that it's turning into chronic. And when those labs are 3 months or more consecutively, it's chronic renal failure. Advancement can be slowed, but it is irreversible. So once you get chronic renal disease, it keeps going. The end result is going to be your ESRD, end stage renal disease. Result either dialysis permanently, or they need transplantation of the kidneys. That's kind of where these chronic renal failures end up. So you can see how nasty these kidneys get with years of damage compared to a normal kidney, the size. Causes. Diabetes, hypertension, those are the big ones. 71% of all chronic renal failure, diabetes and high blood pressure. Those are avoidable problems. That's why USPAs are going to be fighting this high blood pressure, diabetes thing for your entire career because they won't take care of themselves. So they'll come to you. So causes, here's your diabetes, hypertension, and so on and so forth as you go down the list. So chronic injury, irreversible loss of those nephrons. They won't grow back. The tissue's damaged. Increased functional burden is borne by fewer nephrons. So let's say you had 100 nephrons, and that all 100 nephrons had to do this job. Now you cut out 10 people. The stress gets put on those other 90 to support that you still need 100. Well, now if you get loss of 50, and you have 50 nephrons, well, they still have to do the work of 100 nephrons. So the burden gets laced onto all the other remaining nephrons, so then they get stressed out, and then they start to fail. And then it spreads to the other nephrons who are having to pick up the slack, and then they get burnt out and fail. That's why it's like irreversible. You're kind of like pushing the stress onto the next ones, and it just keeps building up until the kidneys finally give up. So again, hyperfiltration is going to happen to the remaining parts. Same amount of blood, but less space to be filtered. So because less space to be filtered, all your products start to build up in the body. So this compensatory hyperfiltration essentially causes hypertension at every single nephron, because that pressure has to be put across, and you have less nephrons to spread that pressure across, so they start to build up, leading to scarring and fibrosis, glomerular sclerosis, leading to further nephron destruction and loss, increasing the uremia, the building up of those uric products. And the degree of interstitial fibrosis determines the amount of impaired renal function. So this is a positive correlation. The more that's damaged, the more impaired the renal function will be. So destruction of the glomeruli result in retention of BUN, creatinine, potassium, phosphorus, leading to hyperkalemia, hypocalcemia, further leading to bone growth arrest, and therefore they have body growth problems. Retention of urine leads to edema and also leads to hypertension, and the decreased red blood cell production leads to anemia. So you see here the three things that deal with what happens when you destroy your kidney function: bone growth problems, skeletal mass because of calcium issues, you can't bring it in anymore, hypertension, we're filling up with fluid, and anemia, red blood cell destruction. Red blood cells can't form because of the EPO. So uremia now we're dealing with these nitrogenous wastes, the uric acid products. Normally, these are all excreted by the kidneys, but we don't have the function anymore, so we can't clear them out, so they start to build up. Increased amounts of hormones that are normally secreted by the kidneys, now they aren't, so they start to build up. And loss of normal substances produced by the kidneys, mainly your erythropoietin as well. We get excretory failure, results in fluid shifts, so start filling up with fluid. We get increased intracellular sodium and water, start to overload. Decreased intracellular potassium because of the aldosterone. Some other clinical manifestations of chronic renal failure: sodium and water excess, hypertension, weight gain, edema, ascites, heart failure, hyponatremia. It's not a true hyponatremia, it's a dilutional one, meaning there's too much solvent in the system, too much water, and it dilutes it out. Hyperkalemia, watch out for those cardiac arrhythmias, we've gone over that a lot, and what happens with our renin system with that. Disorders of calcium and phosphate. So end result, chronic metabolic acidosis in chronic renal failure patients. Osteodystrophy, osteomalacia can develop from lack of calcium, so the bones don't grow right. Cardiopulmonary effects, congestive heart failure, increased renin. They may get some pericarditis from the uremic toxins. Uremia is one of the causes for pericarditis that we learned before. Now we're kind of circling back and filling it back in. Hematologic, they're going to have a normocytic, normochromic anemia. The red blood cells are normal, they're made normal, they're just not being made enough. but everything about them is normal. The red blood cells are okay. They're just not being made. Bone marrow suppression causes increased risk of infections because now you can't make your white blood cells, all that stuff. You may get some increased bruising if you bang into something. Neuromuscular problems with chronic renal failure, sleep issues, some concentration problems, neuromuscular irritability like cramps, twitches, hiccups. Hiccups is a form of clonus. You guys do your bouncing for your ankle for clonus, rhythmic oscillatory contractions. That's what hiccups are, just of your diaphragm. It's clonus. Peripheral neuropathy is big with these patients. Restless leg syndrome is very common in patients with chronic renal failure. GI issues, anorexia, nausea, vomiting, hiccups. Endocrine issues, women will have decreased estrogen. Men, decreased testosterone. Derm issues, so here's some derm changes from an underlying condition. Pallor, skin changes, you may get some ecchymosis and hematosis. Hematomas, we talked about easy bruising with these patients, so obviously the bruising, the ecchymosis would make sense. Uremic frost is the big one. It's like you get very, very sweaty and the sweat evaporates, you're left with like the salt left over. This is, instead of that, these patients will have uremia left on their skin. It's like a uremic frost. I have a picture in a second. But it's dry, itchy, and it's just the urea that persists after evaporation of water, and that's what uremic frost looks like. Oops. There's your uremic frost. It looks like just dried salt, but it's not. The end result is going to be end-stage renal disease, dialysis. This is what dialysis looks like. Obviously, whenever you get to this point, high increased risk for cardiovascular disease, mortality. So they usually die from sort of cardiovascular event, not from the kidney disease itself. Yes?
Is that just from like the fluid overload?
Just the kidneys having to work harder and harder and harder over time. And eventually we talked about how the one failing nephron set will cause stress on the next ones, cause next ones and next ones. So
Like cardiovascular.
yeah,
From the overload of the fluid though?
it's not so much the fluid overload, it's the hypertension that's caused by the extra fluid in the arterioles and breaking the glomerular system up. Risk factors, hypertension, hyperlipidemia, diabetes, high cardiac output, and myocardial calcification. So obviously these are reasons for chronic renal failure or complications from it. 5 stages, again, here is your 60. So between 2 and 3 is your 60 number. So obviously the higher GFR, the better. But when you start getting into these lower 60 and below, we know that around 75% of your nephrons are destroyed. That's why 60 is that magic number to kind of remember for ease. And another way of looking at it graphically, whatever helps, easier to remember. So, bless you. Again, picture remember what happens when end-stage renal disease kicks in. Less than 15 milliliters per minute for GFR is kind of like the cutoff when it's end-stage renal disease. Yes?
For dialysis, the frequency and like duration is determined by
How bad their kidneys are they even working, but the kidney specialists take care of all that. Obviously, we'll refer them when I get dialysis. Usually it's like 3 days a week because your kidneys don't work really, so you need an artificial kidney. That's what dialysis does. It gets rid of all the waste products, helps filter out excess fluid, and dialysis will take care of all that. Next thing we'll go over is polycystic kidney disease, PCKD or PKD. There's 2 different types. Usually, but the characteristic is multiple cysts in the renal parenchyma. It can happen in children and adults. It's an inherited disease, so there's an autosomal dominant trait. Often causes kidney failure because of all these cysts. The kidneys don't work very well anymore. The defects, PKD1 and 2, are the genes. Easy to remember because it's PKD, which is the name of the disease, and so forth. This is what they look like. You have your normal kidney, look at the PKD one. Much massively larger, A lot of cysts, they're not going to work as well, but that's a cystic kidney. There are two types, autosomal recessive PKD, that's usually in infants and young children, usually appears in utero. High rate of neonatal death with this one. The autosomal dominant one is usually in adulthood. So if it was recessive, it's in kids. If it's dominant, it's in adults. So normal cell process is changed. Cell apoptosis, cell polarity, disorganization of surrounding extracellular matrix, excessive fluid secretion, all from these cysts. They're filled with these fluids. They keep draining. You get abnormal expression of those genes start to show up. Cystogenesis, so we're trying to create these cysts now from vasopressin-mediated elevation of cyclic AMP levels start to rise up. So we get a lot of cystogenesis, creation of these new cysts to form. Fluid then secretes into that cyst. We get fluid inside through chloride and aquaporin channels. Cyst formation begins in utero at any point along the nephron. Cysts accumulate fluid, enlarge, separate entirely from that nephron, compress neighboring tissue, because now we're getting bigger, occupying space. It's going to start constricting and compressing neighboring tissue, and it compromises your renal function. So these cysts just get bigger and bigger. They fill with fluid, compress surrounding tissues, destroying nephrons, making kidney function worst. External contours of the kidney are distorted by all these cysts. You will feel this on physical exam. They'll complain of back pain, obviously. Kidneys are markedly increased in size to about 4,500 grams, so about 10 pounds of kidneys. So they get really big, filled with fluid, they get massive, a lot of weight. And here's another example of some kidneys that were removed from polycystic kidney disease. So massive, massive size of kidneys. The autosomal dominant PKD, often diagnosed prior to symptoms at the request of families because it is a genetic test. If someone in your family has this, they will screen everyone else to see if they already have the genes for it. Declines progressively over the next 10 to 20 years, so it's a progressively worsening disease. Not everyone with autosomal dominant PKD develops end-stage renal disease. So not just because you have it doesn't mean you're not going to get chronic kidney disease. Hypertension obviously is going to be common. Mild proteinuria, impaired urinary concentrating ability, so they have some polyuria and some nocturia from all the excess fluid. Here is a scan. You can see how large those kidneys take up space inside the abdominal cavity. Signs and symptoms between 40 and 50. UTIs are very common. Abdominal discomfort from all the mass inside. Back, flank pain, again, mass occupying lesions, move tissue around, and that causes pain. They may get hematuria due to a cyst rupture. So if it bleeds in the kidney, it's going to drain into the calyces, go into the urine eventually, and you'll get blood in the urine. Or you may get some kidney stones. Calcium oxalate is a big one for kidney stones. Obviously, hypertension will be there as well. This type of hypertension, if this person comes in to see you, they aren't that massive in kidneys yet, but they have PKD. You don't know it yet because they don't know. But they come in and you see them and they have high blood pressure, and you give them medication. Will the medication do anything for that patient's blood pressure? No. So whenever you have a patient who's refractory to blood pressure medications, start thinking about other causes of that high blood pressure. The next one to check always is the kidneys. So you'll check BUN and creatinine, and you'll say, oh my God, these are huge, let's elevate it, let's get some scans done. Because we have an elevated BUN creatinine, we'll do an ultrasound, and we're gonna see that, well, not that picture, but you will see something showing PKD on ultrasound of the kidneys. So again, you see how it's like just diagnosed of like, oh, I just found it. We didn't know, but we found it throughout the screening, yes.
So, are UTIs like the first?
It's not the first thing, it just could be a complication. These aren't in specific orders or anything, it's just things that could happen. Okay. Systemic problems with people who have autosomal dominant PKD, cerebral aneurysms. Risk goes up for cerebral aneurysms, 2 to 4-fold increased risk of subarachnoid or cerebral hemorrhages from ruptured intracranial aneurysms. What do you think causes that? Hypertension. Bust those vessels, they don't like the pressures, and they pop. Aortic root and annulus dilation, so the whole aortic, the bottom part where it connects to the valve, dilates, causing what type of valve problem? What kind? Aortic regurg, right? Because the aortic valve is widening, so they don't close all the way. Cardiac valve issues, there's your aortic regurg, mitral valve prolapse can also happen with these patients. Hepatic cysts may also occur as well. Okay, we are going to stop here. We'll finish this up tomorrow. Tomorrow we are going to finish up renal and start neuro. I'll see you all tomorrow. Yes.